tell me where is fancy bred, in the heart or in the head? Shakespeare. Although Shakespeare asked these questions near the end of the 10th century, the answer had been known at least to some for more than 2 millennia. Many ancient Greek scholars, Hippocrates and Plato, among them appreciated that there is something special about the brain and argued that the brain is responsible for behavior in humans and other animals. We now take it for granted that the brain is an organ that obtains information about the environment, processes and stores this information and generates behavior. In addition, it is the brain that is responsible for such vaguely defined aspects of behavior as feeling, aspiration and abstract thought. Those qualities we consider with more than a touch of hubris are quite essentially human. Disease of the brain, which often are associated with aging and hence are the increase as the human lifespan lengthens, cause untold suffering for individuals, families and society as a whole. In essence, then it is the brain that makes up what we are, and indeed it can be argued that all other organs are there simply to support the brain. For this reason, understanding the biology of brain function is a major goal of modern science. The brain is one of the last great frontiers in the biological science, and unrevealing its mysteries is comparable to the complexity and intellectual challenge to the search for the elementary particles of matter or the effort to explore space. In this few lines, you can imagine the role of human brain. It is now human embryos of different CR length. This was collected by me to present a paper in some anatomical society conference. You can see the small tiny embryo. These embryos, these are the skull, developing skull I opened up, and now here you can see the brain, the skull bones, developing skull bones. This is the fetus, and you can see the brain, the two cerebral hemispheres. These are the sulci and gyri are developing. Now, sulci, gyri in embryo, this fetus, but I called it Einstein's brain because it was a bit matured as compared to other fetuses. Now, see, you will be know the ventricle of the brain, ventricles of the brain. There are 4 ventricles. This is again the from the posterior aspect. It is the showing. Now, now this is the dissected brain and spinal cord of human fetuses. Again, you can imagine the brain and the spinal cord length. And this is the fetus that is dissected. Now this, I am telling the fetus is such a fragile tissues. Over there with the, there is no such, I could get some tool to cut it. So I went for a nail clipper. The ladies are using, there are different, and you have a nail cutter, but nail clipper is, you know that it is. Now, I cut the individual bones and removed it and the spinal cord. Now, now areas of the brain, you can see just, this is the cerebral hemisphere, this is the cerebellum, and see these are the areas, prefrontal cortex, Broca's area, premotor area, motor cortex, primary somatic, parietal lobe, gustatory areas, left cerebral hemisphere is there. Now primary, these words you just remember, the brain as a structure, the frontal lobe, parietal lobe, occipital lobe, and the cerebellum. Now you can see the undersurface of the brain. When you see in the specimen, when the department dissection hall, when you will be studying nervous system as a part, then you just turn, this is the like the two hemispheres, but this you see the undersurface. Undersurface is major external parts of the human brain. You can, the frontal lobe, olfactory bulb, temporal lobe, pons, and the cerebellum. This is medulla oblongata. Now, you just know the names today. Go back and just view in the atlas or your textbook what is the. Now, this is the cerebellum cut open. You can see this is the specimen. This is cerebellum, medulla, and these are the fissures of the cerebellum. Now, you can see location of cerebellum, where it is located. See, it is located here. These are the, in blue, these are the venous sinuses. You can see the left lobe, cerebral hemisphere, right cerebral, and you can see the medulla oblongata. Now, parts of the cerebellum, when you read cerebellum, you will go into detail. Now, a pair of cerebral hemispheres united by the vermis. This is the vermis, worm shape it. Now, again, each cerebral hemispheres has the following features: surfaces, borders, notches. Surfaces, borders, notches. You just know the idea. You have an idea. Now, again, the vermis cerebelli is divided into two parts. These are the lobes. Now, you see the cerebellar connections. Superior cerebellar peduncle, cerebellar from nucleus interpolatus and dentate nucleus, ascending portion. These are the connections of the brain, and it has now middle cerebral peduncle, superior cerebral peduncle, and these are the fibers. Now, classification by phylogenetic and ontogenic development. Now, this is the archicerebellum, paleocerebellum, and neurocerebellum. Classification by afferent connections, vestibulocerebellum, spinocerebellum, pentocerebellum. Classification by afferent connections by vermis, paravermal region, and cerebral hemispheres. Now, this is the picture, deep nucleus. These you will be studying in detail. You can see the different nuclei, dentate, embolism, globose, fascicle. These are the subcortical collection of grey matter arranged lateral and to medial R. Now, cerebellar peduncles, see superior brachium conjunctum. This is the cerebral peduncle, pons is here, medulla oblongata is here. This is the olive. This is the posterolateral view, posterolateral view. When you see the specimen in the department, you can see all these parts. Now, the blood supply, arterial supply, superior cerebellar artery, anterior inferior cerebellar artery, posterior inferior cerebellar. Venous drainage, superior cerebral veins drain into the straight sinus. All this drains into the sinuses of the thing, and then goes into the now the cerebellum is the head ganglion of the proprioceptive system, since it receives impulses from the muscles of the limb, trunk, and face, etc. Proprioceptive sensation. Now, if there is any cerebellar disorder or some disease or some injury, then the gait and everything changes. That is the person aged. Now, it has an ataxic gait. Ataxic Gait. Okay. Now, plus impulse of the muscles, limb, trunk and face. This whole gait changes. Now, it controls tone, posture and equilibrium. See, I am showing you, it controls the tone, posture and equilibrium. It is concerned with unconsciousness impulses, and especially kinesthetic, vestibular, which controls tone, posture and equilibrium. Function of the cerebellum showing the balance. You can see in the rope trick, and you can see the motor skill, function of the cerebellum. Function of cerebellum, it exerts synergistic control. The control of cerebellum is ipsilateral. Now, these you will be studying in physiology and also in anatomy. You just give you an idea. See cerebral ataxia. See the gait, how the gait changes with ataxic gait and your position, left cerebellar tumor. See, these are the gait. So, you have heard of Vidhan Rai. So, his having his knowledge in clinical medicine is such that a patient is coming like this, he goes in like this. Now, he diagnoses without touching, but that there was no scan, MRI or in those days. But clinically, you will be able to diagnose more than 80% diseases. Because a study in USA, some 1,000 MRI and CT scans, they have come to a conclusion that it is not so effective as a feather, your hammer, your pin, that these reflexes or whatever is responding, it is more effective. Now, of course, with modern this thing you have to correlate. But the day a patient comes to your clinic or your this thing, you frame up. If you have say 50 patients in your clinic, then at least one might come as with this type of problem. So you take your time and clinically you try to diagnose, because every MRI or any report, even simple hematology report, in the footnote there will be a star like this. Whoever is concerned, the radiologist, pathologist, anything, please correlate clinically. So, is it that he's leaving his duty, কর্তব্য ওখানে শেষ করছে by writing this footnote? Okay. Now you these cerebellar relations I won't go into. Now, then nystagmus, the eye displays oscillatory movements when they are fixed to an object. The eyes tend to deviate from the control position 10 to 30 degrees to the opposite side. Now, it is oscillating করে. তুমি দেখবে চোখটা, when you see, you do a routine neutralization, you have a torch with you. Okay, torch means of course the torch is replaced by the mobile phone. Anyway, you just see and then you will see that it is moving like this. So, you will at least try to come to a diagnosis that it is a, there might be, even you have a question in your head that it is a cerebellar lesion. Okay. Now, cerebellar medulloblastoma. The cerebellar medulla is there. Now, it has a tumor in this child. Now, see cerebellar tumors on vermis, truncal ataxia, frequent falling. The child in this position would not try to stand unsupported, would not let go of the bed rail, or if she was stood in the floor. যদি ফ্লোরে থাকে তাহলে মুভমেন্ট করবে না, যদি করে তো সাপোর্ট নেবে। He will take the support of some of this thing. Now, now the cranial nerves. Now the cranial nerves, you will be having again the cranial nerve, the olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. This will be taught to you in your classes, but I am just giving you a glimpse. Now, sensory nerves, amongst the cranial nerves, sensory nerves 1, 2, and 8. Motor nerves are 3rd nerve, 4th nerves, 6th nerve, 12th nerve. Mixed nerves are 5th nerve, 7th nerve, 9th nerve, 10th nerve, 11th nerve. Now again the cranial nerve nuclei. You see the all the nerves on the undersurface. The major portion is coming from the undersurface, and then it goes to the to different foramina of the skull. On the base of the skull, when it will be taught to you, you will see that different foramina, and through that the nerve goes. Now again, see, it's a nice illustration. See, olfactory, this is the lateral surface, sagittal section of the brain. When you see the skull, in soft tissue specimen, you will see this pattern. This is the eye. This is again the muscle that is supplied by the oculomotor nerve. Now, these are the facial muscles. You can see the cochlea. Now, you see olfactory nerve, optic nerve, trigeminal nerve, now ophthalmic nerve, maxillary nerve, and mandibular nerve. That's why it's called trigeminal. That's why it's called trigeminal. Now facial nerve. See the now vestibulocochlear. This is the cochlear apparatus, the external auditory canal, and this is the stapes, and now glossopharyngeal. See the glossopharyngeal nerve, the tympanic membrane, tonsils, glossopharyngeal nerve, carotid artery. The nerve supplies here in the tympanic membrane. So, you take a hot food, a starter, with that smoke and a special chili from Assam. It's very hot. I tell my my child that I'll make us prepare chowmin for you, and it will come such hot that your smoke will come out from the other ear. Just a joke. Okay. Now, Tajiri Bolera, you take a hot chili in your tongue, taste, it becomes blushes, it becomes red. Okay. Now the vagus nerve, hypoglossal nerve. Now see the hypoglossal nerve in this. This is the relation. Now this is the mandible, it's cut, this portion, and you are seeing from the side. Now tracts of the spinal cord, you will be reading in physiology, the ascending, descending tracts, and upper motor lesion, lower motor neuron lesion. These are the, at what levels are there, okay. Now, receptors, the extroreceptors, proprioceptors, enteroceptors, non-encapsulated, encapsulated. Mesenous corpuscle, fasciculus corpuscle, Golgi body, muscle spindle. When you are taught the tracts in physiology, these reflexes, plus in anatomy, we will be telling you. Now, ascending tracts, you see ascending. Now, lateral spinothalamic tract. You can see the lateral spinothalamic tract, how it goes to the brain. These are the nuclei. Now, anterior spinal thalamic tract, touch and pressure, crudely localized. Posterior spinocerebellar tract, posterior spinocerebellar tract, third lumbar vertebra, muscle spindle, Golgi tendon, organ, joint, receptors from trunk and lower limb, unconscious proprioceptive touch pressure, posture and movement. Again, anterior spinocerebellar tract, proprioception from lower limb and general status of posture. Okay. Now, if anywhere there is an injury, then that function is lost. Now, posterior column tracts. See, this is the place. Posterior column tract, proprioception, vibration, fine touch, 2-point discrimination, tactile localization, and stereognosis. Like tactile discrimination. Then stereognosis. See, if you have a coin, 1 rupee, 2 rupees, 1 paisa or 10 paisa, you feel and you just feel and tell that this is this. If I put your spectacles in a table, then it is dark, the room is dark. What you will go, your mom's spectacle is there and your own spectacle is there. Then you go and in the dark, and then you take one spectacle and you just feel the frame, and that is stereognosis. How you are identifying. Your mom's frame will be small, your will be much large frame. Okay. Now, cortico-spinal tract. You can see the path. Rubrospinal tract. Vestibulospinal tract. This just know the terminology. Then you read and see the book, because I'm just introducing the terminology and the place where it is located. Reticulospinal tract, reticular fibers. Tectospinal tract. Olivospinal tract. Lesions of spinal cord. Now, spinal cord injuries. Now, lesions of the spinal cord injuries, traumatic, accident, gunshot, fall, stab wounds, fractures, dislocation, ligament tear. Non-traumatic, disc prolapse, infection, abscess formation, vertebral subluxation, and spinal neoplasm. Abscess. Which abscess? Which abscess is very common in our country? It is tubercular abscess. See, a person comes with a swelling at the back, and little bit he goes like this, like this. That means the infective focus in some vertebra is there. That fractured. Naturally, the abscess slowly moves down, and it is non-traumatic. Then disc prolapse. When you read the vertebra, you will see the two vertebra, there's in between there's a disc. to give you the flexibility and movement. Even you sit down like this, you go down like this, you dance like this, you dance like this. Now, you see the dancers, that is totally, the brain is controlling. Now complete transection. Complete transection. Above third cervical segment, paralysis of respiratory muscles and unable to survive. Now, if in an emergency, you see a patient coming up with a crash, car or motorbike or anything, he's gasping, you, of course, oxygen support and whatever it is. By the time you have portable x-rays, just do a x-ray, and if you see above third cervical segment, first, second, third cervical segment, paralysis of respiratory muscles, unable to survive. You have to, after seeing this patient, you come quick and tell the patient that we are trying the best, level best, whatever with resources I have and this thing. Or you are in a simple chamber, someone calls you, sir, doctor, dekun. Quickly you have to attend something. Then you go to the hospital because he's got injured over here. Okay, now below fifth cervical, quadriplegic, paraplegic, complete loss of all sensation and voluntary movement. Quadriplegic means upper, lower, both gone, paralysis, quadriplegic. Then paraplegic, it can be just, it can be the lower limb or the upper limb. Now incomplete lesions, anterior cord syndrome, posterior cord syndrome, central cord syndrome, Brown-Séquard syndrome. Now lesions of the spinal cord. Now you can see complete cord transection syndrome, anterior cord syndrome. Okay. Now central cord syndrome, the whole portion. Now Brown-Séquard, this portion, of half of the thing. Now anterior cord syndrome, it has a flexion injury, dislocation, disc prolapse, wedge fractures of vertebral border, contusion injury to anterior spinal artery. These are the levels C4, C7, C12, L1. Now posterior cord syndrome, rare condition, it's a rare condition. So fracture of posterior elements, avulsion fracture. Central cord syndrome, hyperextension injury, whiplash injury, congenital or degenerative narrowing of the spinal cord, more severe involvement of upper extremities, sacral sparing. Brown-Séquard syndrome, now hemisection of the spinal cord, stab wounds, compression due to extramedullary tumors. On the side of lesion, damage of posterior funiculus, pyramidal tracts. On the contralateral side, damage to lateral spinothalamic tract. Now, Brown-Séquard syndrome, lesion on this side, total loss of all sensation, hypotonic paralysis, this loss of tactile discrimination, vibratory and proprioceptive senses, spastic paralysis, and loss of pain and temperature sensation, impaired tactile sensation. So, you in the emergency, you try to take a note, you just draw one rough sketch, man standing like this, you try to, whatever your findings are, you send the emergency, let it be resuscitated, the patient, then it is ordered that your treatment sheet. So, you quickly give your findings, okay, because that gives the clue to the senior physician and the person concerned, then you go support the neuromedicine people from upper motor neural lesion, lower motor neural lesion, syringomelia. Syringomelia is area in which sensation of pain and temperature are lost. This clinical manifestation of spinal cord lesion. Now, the spinal shock, the period of areflexia, abrupt withdrawal of connection between higher centers and spinal cord, loss of all reflexes. So you have a hammer in your pocket, in your apron pocket. When you are doing an emergency duty, you always test the reflexes. If you are doing a ward, medicine ward, then even in diabetes, you must, like Professor Prodhoy Mitro, our teacher in those days, he had a habit of tuck, tuck, all the reflexes, especially lower limb reflexes, because you make an assessment and you make it a habit. You have to make it a habit, cultivate a habit, and correlate your now blood supply of the brain. Now arterial supply of the brain is derived from two pairs of vessels, internal carotid arteries and vertebral arteries. Then you will go to the brain that are Circle of Willis, the supply of the brain, but main is the carotid arteries and the vertebral arteries. That is the main thing. Whatever they ask you a question, then at least what supplies the brain? And you say the carotid arteries and the vertebral arteries, they supply. After then, if you say Circle of Willis, they supply the brain and total. Now you can see your internal carotid artery. Yeah. Now these are the posterior communicating anterior choroidal middle arteries. So you will be thinking in detail. Now this is the Circle of Willis, is supplying the brain. Okay. Now anterior, middle and posterior cerebral arteries give rise to two sets of branches. Central branches consist of 6. That will be, you will be writing in detail. That can come as a short question, Circle of Willis. That means you have to mention all this. Okay. Now cerebral cortex is supplied by cortical branches. Now these are the supplying the areas of the brain. Now arteries supplying the internal capsule. This is a very, what are the arteries supply in this internal capsule? But if there is a cerebral hemorrhage, you can understand the paralysis and this thing, then immediately you think of internal capsule. That you do a CT scan brain with dye, then you will get the hemorrhagic area. Now arteries supplying the thalamus, arteries supplying the corpus luteum, arteries supplying the brain stem and the cerebellum, blood supply of the anterior spinal arteries and posterior spinal arteries. Blood supply of the spinal cord is the anterior spinal arteries and posterior spinal arteries. Veins of the brain, they are classified as veins of the cerebral hemisphere, cerebellar veins, veins of brain stem. Now, cerebral veins are divisible into external group and internal group. You can see the group here. Now, this is the veins of the cerebellum. I told you the petrosal, sigmoid, occipital and petrosal sinus. The dural venous sinuses, this is all in blue, you can see. Pterygoid venous plexus, this is the place where the pterygoid venous plexus. meninges of the brain. See, this is the skull, this is the dura mater, arachnoid matter, and this is the pia mater here. That is the brain. It is a thin membrane, like it is a very thin. It is adherent, more or less adherent. You try to, but you can take out with the forceps. Okay. Now, ventricles of the brain. Third ventricle of the brain. Just know the names. Lateral walls of the ventricles. This is both sides. Two hemispheres. Lateral ventricles. Then anterior wall of the third ventricle. Posterior wall, roof and floor of the third ventricle. These can be your short questions. The ventricle, fourth ventricle, third ventricle, corpus callosum. Okay. Now, hydrocephalus. Nowadays you don't usually encounter because we are doing NT scan at 10th, 11th week, and 18 to 22 weeks you do anomaly scan. You try to see in a high resolution 3D imaging of the ultrasound. You must, even if you, for a GP, any antenatal, when a mother comes with a pregnancy, you ask her the period of amenorrhea with last date of LMP, last date of menstruation. You note them and expected date you calculate, and in between roughly 3 months, 2 months, patient says it. Okay, she can be a bit mistaken for, because whatever, but nowadays even the village people, ladies, girls, they will give you more or less the date. Okay. Now, composed of midbrain, pons and medulla. What is the brainstem? Describe the brainstem. Or it will be comprised of your midbrain, pons and medulla. Pons situated in front of the cerebellum. I showed you the slide on. Now, here's the brainstem. You just simple draw, and midbrain, pons, medulla oblongata, cerebellum. Okay? You start practicing. You just practice. Okay. Now, brainstem structures, you will see. Spinal cord. It is the elongated cylindrical part of the CNS, suspended in the vertebral column, surrounded by meninges and CSF. Continues above. Now, the spinal cord you see as such. Spinal cord internal structures, so there, internal structures of the spinal cord. Now, you see the dura mater, the spinal nerve, the arachnoid matter, the dura mater here, the pia mater, and the spinal cord. We have a specimen in the department. You please, when you study neuroanatomy, you please see it. Hath diye dekhe nebe, chhirbe na. Don't distort. Every specimen is precious. Now, spinal cord cross section. Now, flexion and rotational injury. See the picture with you get a fracture like this. Flexion, rotation injury. Crush injury. You fall from this. See what type of injury in the vertebra. This falls like this. Flexion injury falls climb from height. Dum fatas, like this. Okay. Now, in that, he gets an injury there, and you will, the effect will be on the spinal cord. Now, this is an extension injury, head-on collision in a high your speed car going on a long drive from Second Bridge, Howrah, going to Digha. You have to reach by 3 hours or 4 hours. Don't. You go for a night out, but be careful. Chance fracture, this is the fracture. So if you see a radiograph, you diagnose as a chance fracture. Then immediately you give a support with a belt. It's a thoracolumbar brace that can give a support and transport, because this needs a intervention of the orthopedics and neurosurgeon. If you diagnose and refer to the correct people, then you get 100 marks. The patient will come back to you again and give you a thank you. Okay? Now, atlantoaxial injuries. See, this is the spinal cord, this is the vertebra, this is the odontoid process, and see this fracture. Atlantoaxial injuries, fracture dislocation, only dislocation. Tuberculosis spine, cold abscesses, which I told you earlier, that see the abscesses, yeah, and you see the anterior. This abscess can travel from thoracic vertebra up to the psoas muscle and come out in the pelvis. Okay. Don't try to you give an incision, you think of an abscess and give an incision. Don't. Get into the investigation, then you go, you give a supportive brace, and also what you have to do is that you give anti-tubercular drugs. Then it subsides to some extent, because you have to give a regime of 6 months minimum, or it can be extended according to the severity of the infection. Now, spinal cord tumors, see this tumor here. Now, see the X-ray spine here, fracture. See, this is an MRI of spine here at this level, dorsal line here, the spinal cord. Now, blood supply and dural venous sinuses. This picture is taken from your Auckland's Atlas. Auckland's Atlas. Those 5 volumes, I've told you to take it in your pen drive. Anyway, it's just a window you are seeing, but the thing is big. Window you are seeing the sky, you have some limit. But when you go outside and see the sky, it is a big show. But don't panic. Neuroanatomy, of course, we used to fear. But you have such good books, and your books are sufficient, and your atlases are sufficient, your whatever mode you want to study, but you draw some sketches, Always when you are studying, you draw some sketches. Kichu na spinal cord aakar to osubidha nehi. So you draw sketches and label them. You have a book in your side, and then go, you draw, and study anatomy, especially bones, or you want to give a mock test amongst your friends in group of 4, group of 2, whatever it is. Wherever you are comfortable, and this thing. Thank you.